You're good.
Hi, welcome to this afternoon's Facebook Live. I'm here with Dr. Christopher Hugge. He is a SLUCare physician at SSM Health Cardinal Glennon Children's Hospital. And today he is going to be talking to us about bleeding disorders in children. He treats patients with bone disorders, blood and platelet disorders, and specializes in treating pediatric patients with hemophilia, sickle cell anemia, von Willebrand disease, and Wilms tumor. We'll take questions live throughout the presentation today, so feel free to leave those in the comments. Dr. Hugge, take it away.
Great, thank you. And thank you for all the, I'm certain millions of people out there in the ethos who are watching this. We just had a rehearsal of this talk and we nailed it, so hopefully it's just as exciting the second time around. So I've been asked to talk to you guys about bleeding disorders in children. I'm going to be referring to a PowerPoint presentation that I put together just to help explain maybe some of the things that I'm talking about, and also to help prompt me with my presentation. So I wanted to really start by reviewing what normal blood clotting is. We call blood clotting hemostasis. So when you get a cut, this is a blood vessel, and this right here is a disruption in the blood vessel. A lot of things start going on. It's a pretty complex process, and the first process of this is called primary hemostasis. So it's the first part of blood clotting. There's a lot of different moving parts here. So we have these cells in our circulation in our bloodstream called platelets, and usually they just float around and are nice and happy floating in the bloodstream. But once a blood vessel is injured, they change shape and they start sticking together. They stick to what's underneath the blood vessel, which is collagen down here, using a kind of like a glue. We call it von Willebrand's factor. It's a protein that helps the collagen stick to the platelets and form that initial plug. The platelets release a whole bunch of different chemicals that activate other platelets, and ultimately you get this propagation of what we call platelet plug and decreasing in bleeding. Now, unfortunately, if that's all that happened, the blood flowing past this would very quickly knock that really cork out of that defect. So we need something a little bit more stable. That's where we get into secondary hemostasis. So the next process of blood clotting is really a compilation of a number of different proteins that all come together to make a protein called fibrin. This cascade of events I'm not going to go into in a whole lot of detail. This is the stuff of nightmares for medical students. These cascades we spend hours and hours and hours trying to memorize, and then very shortly sometimes forget. Fortunately, I do this for a living, so I know this cascade quite well, but I'm not going to really go into a whole lot of detail for you guys. Needless to say, it's a bunch of different proteins. They're all named after Roman numerals. And protein 11, for example, activates protein 9, which activates protein 10 with the help of protein 8, and all the way down the line until you get fibrinogen, which then becomes fibrin. And what does fibrin look like under the microscope? This is what a nice stable blood clot will end up looking like. All these little tendrils and netting, that's all fibrin kind of stuck together. And this is really what holds a blood clot in place and what makes it really, really stable and steady. And when this forms normally, this is when bleeding stops. And so this is what you want to happen. Unfortunately, because it's such a complex process, defects in any one of those steps, whether primary hemostasis or secondary hemostasis, can cause an abnormality in the cascade, and ultimately an inability to form a nice stable blood clot, and bleeding symptoms arise. When we see patients in the hospital or in our office with a complaint of abnormal bleeding or a concern for bleeding, one of the biggest challenges is really defining what that means. What is abnormal bleeding versus what constitutes normal bleeding. Everybody bleeds. Anybody who's a parent and anybody who's been around long enough knows that scrapes happen. Bloody noses happen, so bleeding is a part of life. And so when does it go from a normal part of life to something that's abnormal? And that's really what we have to figure out. We see a number of patients coming in for pretty common bleeding symptoms. So the most common referrals that we get in our office are for children who have potentially excessive bruising, or for kids that have bloody noses, or for adolescent girls who have what they feel as heavy periods. And these are often subjective types of symptoms. What might be abnormal for one person may be completely normal for somebody else. it's important then to understand the history, behind the bleeding symptoms and the context, under which the bleeding symptoms first arose. If you look at this poor guy right here, he looks like he kind of deserves this bloody nose. You may be able to tell that his nose is not on his face exactly straight. He looks relatively content with whatever he did that got his nose looking like this and all this bleeding. But understanding that, might lead us to believe that this amount of bleeding was probably normal in this set of circumstances. And so understanding those things helps us ultimately decide who needs more of an evaluation and more of a workup. There are kids that we see who, after a very careful history and physical exam, we determine after a conversation with the family that maybe the bleeding that you're seeing is actually normal, and we don't need to do anything else, and we can just observe. And then there are other kids where the bleeding symptoms are clearly not normal, and we have to take that evaluation a little further. We have the luxury of having a way to quantify bleeding symptoms. There's a pediatric bleeding questionnaire that we utilize in our patient encounters when we see a new family. And it's really just a compilation of a number of different bleeding symptoms: bleeding from the nose, the skin, minor wounds, bleeding after having a baby, etc., etc. And a score is actually attached to each one of those symptoms. And so we'll go through each one of those symptoms, ask about frequency, how long it takes to stop the bleeding, whether you've needed to have a consultation with a specialist for the bleeding, etc., etc., etc. And then we develop a total score. It's particularly helpful in those kids who have really low scores. So kids that have a score less than 2, for example, almost never have a diagnosable bleeding disorder. And it can allow us to then talk to the family and say, we don't really feel like we need to take this evaluation much further, because the bleeding symptoms that you're experiencing really probably fall along a very normal pattern of bleeding. Whereas those patients who have very high bleeding scores, it really behooves us to take that evaluation further and look into trying to establish a diagnosis or a reason for the bleeding. What are common bleeding disorders that we encounter in the pediatric population? I think most people, when they think about bleeding disorders, will be familiar with hemophilia. Just as a note, this slide I've used is stolen from the internet. I just like the graphics. It actually tells you nothing about hemophilia or how hemophilia works. These spiky little balls represent really nothing in their natural world. So if these are circulating in your bloodstream, you don't have hemophilia, you have something far, far worse. Fortunately, they don't exist. But what is hemophilia? We're going back to that coagulation cascade that I think I probably told you not to think too much about. But this is secondary hemostasis again. This is the second part of coagulation, where you form that fibrin blood clot, that netting. And what hemophilia is, it's a deficiency in one of 2 proteins. So patients who have the more common form of hemophilia, called hemophilia A, are missing factor 8. And then patients who have a less common form of hemophilia, called hemophilia B, have deficiencies in factor 9. Both lead to very similar bleeding disorders. And what type of bleeding do you see in these conditions? Usually not subtle bleeding symptoms. So these are generally not bleeding disorders that present with either subtle symptoms or later on in life. These are typically bleeding disorders that present very, very early on in life, with pretty impressive bleeding within what we call soft, deep soft tissue sites. So joint bleeds would be the classic site of bleeding for a patient with hemophilia. Muscle bleeds, so bleeding into the muscle, would be another common site. These are very, generally very obvious bleeding episodes, very painful, and fortunately, in today's day and age, you almost never see a bleeding episode like this. We have really good ways to manage these patients to help treat bleeding before it gets to this point, and really to help prevent bleeding in the vast majority of our patients with hemophilia. So it really is a different disease now compared to 40 or 50 years ago. So switching gears to something that's certainly more common and probably a little bit more pertinent to the audience at large is a condition called von Willebrand's disease, probably the most common bleeding disorder that we see in the pediatric population. We're now sort of back to primary hemostasis, so that first part of blood clotting where you form that platelet plug. And this is von Willebrand's factor right here. And what von Willebrand's factor does is it sits in the blood vessel walls and it circulates in the bloodstream and acts as a glue. It attaches to collagen underneath the blood vessel, which would be down here, and then attaches to the platelets and helps those platelets to adhere a little bit more firmly so they're not easily knocked off the site of injury. This is just another schematic just to show you that on von Willebrand's factor, on that protein, there's an area that will bind, stick to platelets, and then there's another area that reaches out and grabs onto collagen. So it almost like it has two arms. One arm grabs the platelet and one arm grabs the collagen and functions as that glue or sealant. Again, historically, it's considered the most common bleeding disorder. So as a medical student, you learn that about 1 to 2% of the population has low levels of von Willebrand's factor. That in the past led to a lot of patients being diagnosed with von Willebrand's disease. The frustrating part, or what we've really realized over the last maybe 10 to 20 years, is that many of those patients who have low levels of von Willebrand's factor never have bleeding symptoms ever. So there's really a lack of consistency in terms of what your levels are and what your bleeding symptoms are. So if you really want to label somebody as having a disease, I feel very strongly you need to have symptoms. And so that probably brings the frequency of this bleeding disorder to about 1 in 1,000, but still fairly common. We have a lot of patients that we follow with this condition. The bleeding symptoms are different from hemophilia. The bleeding symptoms are more what we call mucocutaneous. So muco, really referring to the lining of the mouth, the lining of the nose, the lining of the intestinal tract, and then cutaneous really refers to skin. So this is bleeding that occurs mostly in the skin and the mouth and nose for all practical purposes. So we have patients that have excessive bruising. We have patients that have recurrent nosebleeds, patients, adolescent girls who have heavy periods, some kids who will have a lot of bleeding, excessive bleeding after a tooth is removed or a tonsil is taken out. Most of these bleeding symptoms are not medically emergent. So these are symptoms that we often talk to families about as being nuisance type bleeding. A nosebleed that just keeps on happening, every other day, every week. So rarely are these bleeding symptoms that require acute management in a very short period of time. So it allows us an opportunity to teach the family how to manage things often at home. I want to finish off at least with the common bleeding disorders by talking about platelet disorders. We see a number of patients every year with platelet disorders. They're probably as a group as common as von Willebrand's disease. These again are platelets that have been activated and want to stick. And the problem with platelet disorders is there's either not enough of them or they don't change shape from this nice little round disc to this activated form that gets really sticky. And one of the hallmarks of a platelet function disorder are these, is a rash. It's called a petechial rash, and you may not be able to see it on the screen, but they're very bright red dots, and they don't blanch. So whereas a hive, you press on your skin and the hive kind of goes away for a short period of time, and then the pink color comes back. Petechiae and bigger petechiae called purpura, they don't blanch. So that would be a sign that that's what you're dealing with. The most common platelet disorder we see is something called ITP. It's an immune system disorder where you actually make antibodies, these little Ys or proteins called antibodies that attach abnormally to platelets, and your body deals with those platelets like they might be an infection and gets rid of them and clears them. It's fortunately a self-limited condition in most kids and isn't associated with a whole lot of bleeding symptoms. You'll often have this very prominent, what we call petechial rash, easy bruising. Some kids will have epistaxis, nosebleeds, bleeding around the gums and in the mouth. Very, very rarely do we have more serious bleeding symptoms. So it's usually a very easily managed condition, and a condition that just goes away on its own, oftentimes without any specific medical therapy. So when we see patients with a complaint or a concern for bleeding disorder, how do we work them up? That's obviously dictated by a lot of factors, and I think we went into some of those earlier on, but certainly the history is important. What precipitated the bleeding? Was it an obvious trauma, or was it spontaneous? Where is the bleeding? Bleeding from the nose and the mouth might make us focus on bleeding disorders that affect primary hemostasis, mucocutaneous symptoms. So we may not worry so much about hemophilia and may not have to think too much about that. Family history is often very helpful. So we do sometimes have the luxury of having families that come in with a child who may have bleeding symptoms, who just learned the other day that they had a maternal uncle who had hemophilia or may have had hemophilia, and that helps us focus our evaluation for some of our patients. When we do a workup, we start with common things. We don't look for every single possible bleeding disorder that's been known to man, because many of these are very, very rare. So we typically send tests that are easily available and that come back in a fairly short period of time as our initial screening. So we'll check something called a PT and PTT that looks at that big cascade of proteins, factor 12 and 11 and 9 and 8 and 7 on down the line, and is a very rapid and quick test to rule out most of those deficiencies. So a normal PTT essentially rules out hemophilia without having to do any other evaluation. We can send von Willebrand protein levels and see how von Willebrand's protein works. We can check the CBC to see what your platelet count is. We can actually check and see how your platelets function in a test tube in a fairly rapid amount of time. Depending on these results and depending on how suspicious we are that the bleeding symptoms your child has are abnormal, there are many more specialized lab tests that we can send, and those end up being secondary or what we call tertiary lab tests, where we often have the families come in for a second visit or a third visit to complete a workup in order to find a diagnosis if one is to be found. So for parents at home, really, when is it time to worry? When is it time to worry that the bleeding symptoms that you're seeing, the bruising that you're seeing is, taking that step from maybe normal everyday types of things to something that's abnormal? So what I came up with is really a list of questions that you might be able to ask yourself at home, kind of a guide for parents. The first question is, where's the bleeding coming from? Is it a common site that you would expect bleeding or bruising in a child? The shins, the elbows, a child who just, played a soccer game, got hit in the face, and then developed a bloody nose, a half hour later. Those are all sites that you might expect bleeding. But bleeding from the umbilical cord in a baby after the umbilical cord is falling off that persists, might be a sign of something abnormal. Bleeding from a circumcision site that persists over days, may be a sign of something abnormal. Babies get heel sticks to test for different genetic diseases when they're born, and some bleeding disorders may lead to excessive bleeding from that. It just keeps bleeding. It may not be a lot of blood, but it just keeps bleeding. Bleeding from the gastrointestinal tract, from the urinary tract, unusual spots for bruises on the trunk or the buttocks, where you wouldn't necessarily expect a bruise to be located. What's the context of the bleeding? Again, was it trauma? Usually if it's traumatic and you bleed, it's I think a lot of reason to think that probably a normal response. But spontaneous bleeding, bleeding that just kind of comes out of the blue, a nosebleed that just keeps coming, and yet you're not doing anything necessarily that might injure your nose. Is the child constipated and having really hard bowel movements? That might be an explanation for the small amount of blood you see in the stool or on the toilet paper. Did the child just play a recent, really physical hockey game, and that's why they have bruises all over the place all of a sudden? A kid with really bad allergies, might be predisposed to developing nosebleeds. Lots of kids like to pick their nose. That's often a reason to damage the lining of the nose, and maybe a reason to have recurrent nosebleeds. So these types of questions are asked of all of our families and patients when they come in to try and get a better sense as to the concept or the context. And these are questions you can ask at home even. How long does the bleeding take to stop? Bleeding that stops after a few seconds or a few minutes, may not be so abnormal, but bleeding that takes hours to stop, despite adequate pressure, or days, that just keeps recurring from the same spot over and over, that might be something abnormal. How frequently does the bleeding occur? We see some kids who have a nosebleed every 6 months, and I'll be honest, I don't get so worried about that. But a kid who has a nosebleed every 3 days or every week, and that becomes a little bit more concerning. Has the blood loss required some type of medical therapy? Have you needed a transfusion for the amount of blood that you lost? Have you needed iron replacement because you've become iron deficient and anemic? That's above and beyond what you expect for normal bleeding patterns in most patients. So these are things that might, at home make you think, maybe I should get this looked into a little bit more. And then finally, for adolescent girls, in particular, as they start having periods and they start menstruating, how often is there a need to change a pad or a tampon? Changing a pad and tampon every hour that's soaked through may be a sign of abnormal bleeding. Passage of really large blood clots, blood clots that are the size of quarters and above, maybe a sign of some excessive bleeding symptoms. So these are all questions that I think you can address and sort of ask yourself at home without necessarily referring to the pediatric bleeding questionnaire that physicians might have available to them that might clue you in that something else needs to be looked into. ultimately, my recommendation is if you have a concern, you should listen to your gut. You should bring it up with your pediatrician or family physician. But I also recommend that you don't panic. Again, most of the bleeding disorders that we see are not serious bleeding disorders and are not going to lead to life-threatening acute bleeding symptoms. Those are not subtle things, and you're going to know that it's an emergency. For most situations that we deal with, a bloody nose that is taking a while to stop, as an example, you have time. You have time to think about what's going on, time to call somebody, time to try to get the bleeding stopped at home, because most of these bleeding disorders are relatively mild, fortunately. But getting a diagnosis is important. The first way or the first step is contacting your pediatrician. Hope your pediatrician is accessible and nice and happy as this pediatrician seems to be. And then after talking with him or her, you can decide if a consultation with a specialist, a pediatric hematologist, would be warranted. And I'm glad somebody asked where you could find a pediatric hematologist. Well, believe it or not, we have a couple people here, myself included. Dr. Putz is my partner in the hemostasis bleeding disorder clinic here at Cardinal Glennon. We see hundreds of patients every year who have bleeding disorders and blood clotting disorders, and are available 24 hours a day, 365 days a year for our patients and our families to help address problems and questions that they may have. As far as benefits go, to ultimately seeing a specialist if that's needed, oftentimes we can just demystify bleeding. Bleeding is one of those symptoms that I think creates a lot of anxiety. And for us to be able to sit down with parents and actually tell them, your child is going to be okay. Maybe there is a predisposition for bleeding, but this is something we can manage. And if symptoms occur, we can address it, and we can make sure it doesn't become a bigger problem. It allows us to plan for the future. Knowing you have a bleeding disorder allows you to know what activities might be good to avoid. Simple things like taking a trip. Knowing that you have a specific diagnosis, you can have a plan in place for if something does happen. If I'm in an accident, or if I have an injury and I'm bleeding, I know where to go, and I know what to tell the physician at the other hospital who may not know me, but I know what to tell them so that they maybe are able to address my specific bleeding issue. It can help other family members. So many of these conditions are genetic, and making a diagnosis of a bleeding disorder for hemophilia, for example, allows us to identify other family members that may be at risk for having the disease, or may be at risk for passing that disease on to their children in the future. And a lot of families appreciate having that amount of information and knowledge. And ultimately allows us an opportunity to discuss how we're going to manage your child's bleeding symptoms over time. Because most of what we do, honestly, is over the phone. We very rarely have established patients who have a diagnosis come in because of bleeding that they can't manage at home. So a lot of times it's just it's common sense issues like teaching somebody the right way to apply pressure. So this guy here with a bloody nose is doing absolutely everything wrong. He's pinching the bony part of the nose, the nasal bridge. He's not applying pressure to anything that's bleeding. He's got the tissue paper about 1.5 inches away from where the bleeding is. He's not applying pressure, anywhere with this tissue paper. He's just letting this blood come out. So just teaching a family that the right way to do it is to pinch the soft part of the nose for 5 minutes is enough for most of these episodes to stop on their own. It allows us to talk about some over-the-counter therapies that might be available that you can get at Walgreens or CVS over-the-counter. We can prescribe prescription medications, maybe not specific to the bleeding disorder that you have, but that can help control bleeding, bloody noses and heavy periods, etc., etc. And then it allows us to maybe employ some disease-specific therapies. Most of these can be done at home. There's a medicine called DDAVP, for example, that we use in patients with von Willebrand's disease. It's very effective at stopping bleeding. For hemophilia patients, we have what we call factor concentrates. So we have factor 8 that's in a little bottle that we can give. And if push comes to shove and we can't get bleeding stopped at home, there are blood products, blood transfusions that we can employ. It's very, very uncommon that we ever have to do that for our patients, however. So, developing an action plan is important, and that's why addressing your concerns with your pediatrician, getting a referral to a specialist is important. It allows you to know what you can do at home, when to call, and ultimately when to come in again to see these two guys who are always eager and ready to help you with any issues that you may have. So hopefully this has been helpful. We're really at the end of the talk. I want to thank everybody who is out there again on the World Wide Web who has spent the last, 20 or 30 minutes with me learning about bleeding disorders, and I am available for any questions to answer in real time, and I think if questions come in later, I'll also be available to answer them as well. So again, thank you very much.
Thank you, Dr. Hugge. We actually do have a couple of questions after your very informative presentation. So our first question, how common are bleeding disorders?
So I think as a group, bleeding disorders are pretty uncommon, which is fortunate. For as complex as the bleeding cascades are, they're programmed pretty well and they work really well for most patients. Maybe to put things in context, I think I mentioned that clinically significant von Willebrand's disease, which may be our most common bleeding disorder, is maybe in the range of 1 in 1,000 for patients with hemophilia. The more common form, hemophilia A, is about 1 in 5,000 boys, and hemophilia B would be 1 in 30,000 boys. And then the other bleeding disorders that we see, with the exception of platelet function disorders, which may be right around the same frequency as von Willebrand's disease, you're talking about very, very, very few kids, 1 in many hundreds of thousands, if not millions. So it's not a very common common problem.
Right. Our next question is, if my child has a bleeding disorder, are there other health concerns we should worry about?
I think yes. So probably the biggest issue to worry about are ways to avoid putting your child at risk for a more serious bleeding episode. So there are things we do in everyday life that put us at risk for for trauma, for bleeding, I guess, and in particular injuries to vital places, the head, the neck, etc. So we do have recommendations for patients who have bleeding disorders in terms of avoiding certain situations, certain activities. We do recommend avoiding contact sports, for example. Football's probably not a great idea. Ice hockey is not a great idea. Ultimate fighting is probably not a great idea.
High impact,
for
right?
Ultimate fighting for anybody, I guess. But so those are kind of situations that you would be most concerned about. Planning for surgery becomes a little bit more complicated because obviously you're stressing out the blood clotting system when you're performing surgery on somebody who has a blood clotting disorder. So those become fairly special circumstances where you have to identify the potential need for surgery beforehand, and then go through whatever steps you need to make sure things go smoothly, and they do, as long as we are prepared.
And that's why we have you, right?
Exactly.
Speaking of impact sports, my child has a bleeding disorder. What should I do if he gets a concussion or another serious injury?
So generally what we recommend is that you call us right away, and depending on the set of circumstances, again, the context under which the injury occurred, we often have the patients come in either to the office or into the emergency room if it's at night. We will sometimes, based on the injury, suggest getting a CT scan, something to look for any evidence of bleeding inside the head, because that would be obviously something that would need to be addressed right away. And if we have a specific intervention, let's say a patient with hemophilia, we can actually give some of their blood clotting factor right away, and then take whatever steps we need to take to see if they have any bleeding.
Okay. And we have one more question. At what age do these disorders typically present themselves?
That really varies. It's all ages. We have patients with the more serious bleeding disorders, the severe hemophilia patients that we see, that will often present at birth. Sometimes it's because they have a family history and we know to look for it. Sometimes it's because they're bleeding from their circumcision, for example. So we have a lot of patients that come to us from day one. Some of these, more mild bleeding disorders, may not present until, something's done that really stresses the system out. A kid who's been fine all their lives has a tonsillectomy and then for the next week and a half just keeps bleeding. and presents when they're 12 or 13 right after the surgery. So it really varies quite a bit, and some of that is there are a lot of families who just sort of accept that everybody in the family bruises a whole lot, so nobody ever worries about it. That's normal for them. Everybody has nosebleeds, and so it's not until something else happens that they finally come to the attention of a physician.
All right, great. Thank you so much, Dr. Hugge.
Sure.
If you have questions about today's Facebook Live, please call 314-268-4000. And thank you so much for joining us today.